epidemiology is a very versatile specialty. It really speaks to the core of three main things. One is how much of disease there is. Two, what are the factors driving those disease, and they can be clear-cut causes, but sometimes it's not as clear-cut, and it may be just factors that seem to be associated with them, with the outcome. And then the third part, which actually came in later on. If you look at the history, the definition in the early days was confined to those two. But later on, it took on the job of identifying what interventions are worthwhile to ameliorate the problems that you are seeing. So those are the three pillars on which epidemiology rests. But a few years ago, I felt that it needed a little expansion. And I really expanded those three areas and actually got it published about 2015 in an article in the Journal of Clinical Epidemiology, because I thought people needed to understand exactly what we do. And if you were to take those three pillars and then just expand them in a few more, with a little more detail, you would see that if you begin, I may have left out something, so it's how much disease there is in the population. And there are many definitions of population. So it can be a geographic population like Jamaica, but maybe a population of prostitutes or a population of mine workers. So people who share a characteristic. And then we need to, one of the first things we do as epidemiologists is to identify the population. So exactly who are we talking about? To whom can the results be extrapolated? And then there are several other things we do. We define disease. And that's an interesting story because disease definition varies and evolves over time. I take a simple example of hypertension. When I was a youngster in medical school, blood pressure defined as hypertension would be 160/95. I'm sure you know about 120/80. It's a long way between 160. What has caused that? And what really has caused that is the epidemiological evidence, which shows that even at those lower levels, which we thought were normal, disease outcomes are increased. And therefore, one has to revise the definition. And in many cases, that is so. We see it with some of the other diseases, lupus, any disease you can think of. And some of these are moving targets, and we've had to revise them over time. So defining your disease and making that clear, not only because it's gospel at that point in time, but so that it can be reviewed by future researchers and looked at again and say, if we had defined it in another way, would we have come up with some other understandings? And then we go on to look at the factors that are associated and how you measure those associations. And there are many ways of doing that. Ultimately, you get to exactly what you can do. How do you, first of all, how you summarize the evidence and create associations that are useful in the clinical setting. And then you end up with how you intervene, what is justified to intervene. Coming back to the blood pressure example, which is my favorite hobby horse, you may think that a blood pressure of 125/85 increases the risk of stroke or heart attack. But are you justified in exposing that group of patients to medications? Or do the side effects of the medications or the cost of the medication outweigh the benefits of using? And should you then find a cheaper alternative like lifestyle intervention? So that continuous mix of ideas is what goes into. And then finally, you do the circle again because you intervene with approaches which were driven by the data you gathered before, and then you have to monitor and evaluate the impact of that intervention, and it may well generate another set of questions, and you go around again. And so, to summarize that concept, I would say that the epidemiologist, as you may have gathered from what I've said, would be dependent on some older specialties like statistics. You got to count and know what you're counting, demography, medicine, biology. All of these things are underpinnings of epidemiology. But the epidemiologist is not any one of those. It's a person who is open-minded. Because one of the things that you need to keep clear is, I've come to this conclusion now, but how certain am I about this conclusion? What other factors could be explaining what I think I can explain? In the early days of the HIV epidemic, you can only go by what's in front of you. So when the cases emerged in the United States, some factors came out. Multiple sex partners, men having sex with men. But one that we have almost forgotten is that Haitians were a group, Haitians from Haiti were a group of a much higher prevalence of HIV, of what we didn't know as HIV, of AIDS. And in that period, coming from Haiti was a risk factor for AIDS. So at that point, the causal model would include being Haitian. As time emerged, those are the days before we even identified the causative organism. It's almost like back to the cholera epidemic. That before you even recognize the causal organism, you recognize that people who drank a certain source of water got cholera. People who behaved in certain sexual ways got more HIV and got more AIDS in those days. And as biology comes together and more epidemiology comes together and so on, you refine the causal model. And therefore the epidemiologist must always keep an open mind and be willing to revise his or her theory as the evidence emerge. Must recognize the new questions which the answers generate, because every answer generates new question. And must have an agility of mind, must be honest to accept that a hypothesis was totally off mark and let me go again and look with an open mind. So those are the characteristics that make up an epidemiologist, using the tools of many other professions that preceded it, but highlighted by an agility of mind, a willingness to count, and an open-mindedness to accept when your theories may well be wrong and need revision.